Right. I don't see Dr. Cannon is on, so I will facilitate the meeting until if Dr. Cannon is coming later. So we have quorum. The first item of the agenda today is the review and approval of minutes. Do I have a motions to approve the minute from September meeting?
Motion to approve.
Thank you, Colby. Do I have a second?
Second.
Thank you, Dr. Weinstein. All in favor?
Aye.
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 Any opposed? All right, motion passed for the approval of the September minute. The next item is the housekeeping. So Peter, would you like to give us some update?
Of course. Good morning. I have 3 updates that I would like to share. The first one, it is related to Change Health outage system. As you know, the cyber attack on Change Healthcare happened on February 21st, and it affected our point of sale system and disrupting pharmacy operation. So beginning Tuesday, October 15th, the Medicaid fee-for-service point of sales and PRISM provider administered drugs will turn on prior authorization editing. So Medicaid pharmacy will begin accepting prior authorization via fax for pharmacy point of sales drugs and PRISM provider administrating drugs. So that is a great update, improvement. So on Tuesday, October 15th, the prior authorization is going to be turned on. The second update is for ultra cost, high cost drugs definition updates, and also we will have, first of all, let's make sure that we understand what does that mean. The Utah Medicaid defines ultra high cost drugs as medications costing greater than or equal to $1 million per dose. These medications are carved out of the DRG, the diagnosis related group, and the managed care plan, and require prior authorizations as stated in our PDL, the preferred drug list. Providers administrating these ultra high cost drugs, they shall submit the form, which it is in our Medicaid side under the library for reimbursement, and we will audit these services 1 year after the ultra high cost form is submitted. So those forms are all in library. The last update is for melatonin starting September 1st. We started a cover 90-day supply for over-the-counter melatonin for children and adult with the prescription from the healthcare providers. That's all I have.
Thank you, Sapiti. The next update we have is from P&T.
Yes, the P&T committee met in September, and we had our annual update from our ACO partners where each of them presented their PDL methodologies to the P&T committee. And then we also discussed hereditary angioedema with motions to have agents for prophylaxis and acute treatment available as preferred on the PDL.
Thank you, Brian. Next item on the agenda is the presentations from the DRRC.
All right, good morning, everyone. Today, I will be reviewing our utilization review that descriptively measured adherence to oral or long-acting injectable antipsychotics among Utah Medicaid adults with schizophrenia or schizoaffective disorder. I'll also briefly discuss recommendations from recent schizophrenia treatment guidelines related to interventions to promote adherence. Antipsychotics are the mainstay pharmacological treatment for schizophrenia and are an option for treating schizoaffective disorder. Unfortunately, medication non-adherence is common in patients with these conditions, with some evidence estimating that up to 55% of patients with schizophrenia are non-adherent. Factors contributing to non-adherence are multifarious, some being medication-related, such as inconsistently taking doses due to trouble managing complex regimens or due to unpleasant side effects. The potential adverse outcomes of poor adherence to antipsychotics for schizophrenia are severe, including increased risk of relapse or rehospitalization, emergence of aggressive or suicidal behaviors, and death. Available antipsychotic dosage forms depend on the active ingredient, but generally include oral dosage forms such as tablets or capsules, typically administered daily, and/or long-acting injectables or LAIs administered approximately every 2 weeks to every 6 months, depending on the product. We reviewed 2 recent U.S. schizophrenia treatment guidelines from the American Psychiatric Association, or APA, and the Department of Veterans Affairs, Department of Defense, or VA/DoD. These guidelines were primarily reviewed for recommendations on interventions to improve antipsychotic adherence. Both guidelines suggest offering LAI antipsychotics to patients with schizophrenia, either to improve medication adherence or based on patient preference. LAI antipsychotics may be particularly beneficial for patients who struggle with adherence or have a poor response to oral antipsychotics, or those transitioning between healthcare settings. Additionally, early consideration of an LAI antipsychotic may be warranted in patients with limited treatment awareness or a comorbid substance use disorder, as they may be at an increased risk of poor adherence. Importantly, to ensure tolerability in response to an LAI, patients naive to treatment with the LAI's active ingredient should undergo a trial of an oral formulation of the same antipsychotic molecule prior to LAI initiation. Compared to oral antipsychotics, LAI antipsychotics generally offer the advantage of no pill burden, less frequent dosing, and the benefit of regular provider interaction, as they must be administered by a healthcare provider, reducing the likelihood of missed doses. Nonetheless, time constraints of patients and providers, along with transportation challenges, may be barriers to receiving in-office administration of LAIs. Results from a 2021 systematic review and meta-analysis in adults with schizophrenia or other related conditions cited by the VA/DoD guideline, consisting of 32 randomized controlled trials or RCTs, 65 cohort studies, and 40 pre-post studies, showed that LAI antipsychotics were associated with a significantly lower risk of hospitalization or relapse compared to oral antipsychotics. Additionally, meta-analysis results have included studies for which adherence data were available, favored LAI antipsychotics over oral antipsychotics for adherence outcomes. For the retrospective utilization review, we addressed 2 primary objectives: utilization of LAI antipsychotics according to their preference status on the Utah Medicaid PDL, and adherence to oral or LAI antipsychotics among Utah Medicaid adults with schizophrenia or schizoaffective disorder. During the 1-year period from August 2023 through July 2024, 1,875 patients had at least one outpatient pharmacy claim for a PDL-listed LAI antipsychotic. Most of the cohort were male and nearly all were adults. The few pediatric patients receiving LAI therapy were all at least 16 years of age. Of the total cohort, about 25% had a diagnosis code for schizophrenia in their medical claims record during or up to 6 months before the observation period. Of the 12,997 total claims, approximately 97% were for a PDL-preferred LAI product. Based on patient and claim counts, Invega Sustenna was the most common LAI filled during the observation period, followed by Abilify Mantina and then Aristata, all of which are PDL-preferred products. Products of interest for our adherence analysis were oral or LAI antipsychotics, FDA approved for the treatment of schizophrenia or schizoaffective disorder. We classified eligible antipsychotics into regimens depending on oral or LAI formulation. Oral antipsychotics were grouped into the same regimen if they had the same active ingredient and dosage form, irrespective of dosage strength. LAI antipsychotics were grouped into the same regimen if they had the same brand name or generic equivalent for second-generation antipsychotics, or same generic name for first-generation antipsychotics, and if they had the same dosing interval. We queried Utah Medicaid claims data for eligible patients during the observation period from August 2023 through July 2024. Eligible patients were adults who filled at least one antipsychotic of interest during the observation period and who had a diagnosis code for schizophrenia or schizoaffective disorder. Additionally, they had to have at least 2 Medicaid fee-for-service outpatient pharmacy claims for the same oral or LAI regimen, except for Invega Hefira, for which we required at least 1 claim within the observation period, and at least 2 months of continuous Utah Medicaid eligibility, starting from the first fill of an antipsychotic of interest during the observation period. The proportion of days covered, or PDC, was calculated to estimate adherence to antipsychotic regimens. PDCs were calculated 2 different ways, at the population level or patient level. The numerator was the days covered by the antipsychotic regimen. The denominator was the observed days, which was defined as the total number of Medicaid eligible days from the first fill date in the antipsychotic regimen until the date of the first occurrence of a regimen switch, a regimen discontinuation, the end of Medicaid coverage, or the end of the observation period. The population level PDC is an aggregate of the sum of the numerator and denominator days for all eligible patients on a given regimen, whereas the patient level PDC was determined for an individual patient on a given regimen. For all PDC calculations, values of 0.8 or greater were considered adherent. For the numerator, we used the days supply entered in prescription claim fields, or EDS, for oral antipsychotics, whereas we assigned the number of days covered for LAI antipsychotic fills due to poor EDS reliability for LAI products. We assigned 2 different days covered for LAI products using the general recommended maintenance interval, abbreviated GRMI, or the therapeutic interval, abbreviated TI, depending on the analysis. The GRMI is the recommended maintenance dosing interval per labeling for LAIs, and the TI is the longer interval at which point labeling recommends that the patient must receive supplementation with an oral product or LAI injections in addition to the next dose to restore therapeutic levels. The separate adherence analysis calculating the PDC with respect to the TI only included LAI antipsychotics that specified late dose or supplementation information in their product labeling. Switches to a new regimen were when a claim for an antipsychotic differing from the prior regimen occurred after a gap of at least 30 consecutive days with no fills for the prior regimen following the last day covered by the prior regimen. Generally, a regimen switch could include a change to a different LAI or oral regimen. However, there were some exceptions. For example, because oral antipsychotic therapy of the same molecule can be used to supplement LAI injections for very late or missed LAI doses, we considered patients to be continuing their LAI regimen if they filled an oral antipsychotic of the same molecule between 2 claims of the same LAI type. A regimen discontinuation was defined as 30 consecutive days with no fills for that particular regimen after the last day covered of the previous fill in the absence of a switch. Gap days are the days without antipsychotic coverage following the last day covered. Gap days were counted as non-adherent for the period of time that the patient was classified as continuing a medication regimen. For patients classified as having discontinued or switched regimens, days after the end of the supply of the initial regimen were not counted as non-adherent. In addition to the primary analysis, we performed a sensitivity analysis to recalculate the GRMI-based PDCs for oral and LAI regimens using a gap length of 60 and 90 days rather than 30 days in the definitions of regimen switch and discontinuation. Of the 4,352 Utah Medicaid eligible adults identified with at least one claim of an antipsychotic of interest during the observation period, and who had an ICD-10 diagnosis code for schizophrenia or schizoaffective disorder in their medical record, 1,395 met our eligibility criteria. In the total cohort of 1,395 patients, 50% were male and the median age was 37 years. The median duration of Utah Medicaid eligibility was 12 months. The population level PDCs for LA antipsychotic regimens based on the GRMI were high, with each regimen having PDCs of 0.8 or higher. This table shows the PDCs for the LAI regimens with claims from the most patients. Although overall population adherence to LAIs appeared high, the percentage of patients discontinuing LAIs during the observation period was also considerable. For example, at the 30-day gap length, the percentage that discontinued in Vagus Sustaina was 53%, 51% for Abilify Manta, and 41% for Aristata. Generally, across LAI regimens, the percentages of patients who were considered to have switched therapies was lower than the percentage considered to have discontinued. When looking at patient-level PDCs, more than 80% of patients were able to meet a high adherence of a PDC greater than or equal to 0.8 for most LAI regimens. However, the percentage of patients with high adherence fell below 80% for Abilify Manta in the sensitivity analysis. The population-level PDCs for LAI antipsychotic regimens based on the TI were very high, with each regimen having PDCs of 0.9 or higher. When using the TI threshold, the percentages of patients classified as discontinuing were slightly lower compared to the primary analysis: 46% for Invega Sustaina, 42% for Abilify Manta, and 35% for Aristata. The population-level PDCs for oral formulations tended to be high across all gap lengths for most oral antipsychotic regimens, but had variability depending on the gap length. The only oral antipsychotic regimens with a population-level PDC less than 0.8 were aripiprazole solution and prochlorperazine tablet. Discontinuation percentages using a gap length of 30 days ranged from 35% to 58%. According to patient-level PDCs, oral antipsychotic regimens with claims from at least 11 total patients and fewer than 70% of patients with a PDC greater than or equal to 0.8 across any gap length were brexpiprazole tablet, olanzapine orally disintegrating tablet, and risperidone tablet. There are several limitations of our data analysis that should be considered when interpreting the results. Prescription claims were used as a proxy for medication administration, but a prescription claim does not guarantee that the medication was taken or administered. Regarding our adherence analysis, we primarily captured each patient's first observed course for a particular regimen, in addition to regimen switches. However, we did not capture all subsequent courses for each regimen. Our sensitivity analysis using different gap lengths addressed this issue to some extent, catching subsequent courses for the same regimen up to 90 days apart. Population or patient-level PDCs could have been overestimated or underestimated based on misclassification of adherence. For example, we considered patients as discontinued from a regimen if they did not refill the same regimen or switch to a different regimen within 30 to 90 days. But the actual reason for discontinuation is unclear and could be due to non-adherence. This concludes the presentation. Thank you for your time and attention. Please let me know if you have any questions.
Thank you, Dr. Lulo. Does the board have any questions for Dr. Lulo? The next item is we have the public comment from Alkermes for Lobavi. From Kenneth Berry. Are you on the call?
Yes, good morning. Can you hear me?
Yes, we do.
All right, thank you so much.
Yep.
My name is Kenneth Berry. I'm a medical science director and pharmacist with Alkermes, and I want to thank you for the opportunity to provide information on LYBALVI this morning. Please refer to LYBALVI's prescribing information for complete information. Now, LYBALVI is a combination of olanzapine and samidorphan, an opiate receptor antagonist. It is indicated for the treatment of schizophrenia and bipolar I disorder. Samidorphan is an opiate antagonist and can precipitate opiate withdrawal. LYBALVI is contraindicated in patients using opiates, and an opiate-free interval is required prior to initiation. The first study I want to go over this morning is our A308 study, which is a 4-year study assessing the long-term safety, tolerability, and durability of LYBALVI. Eligible patients were enrolled from our Enlighten 1 and 2 studies, as well as our Enlighten Early, which is a 12-week trial comparing LYBALVI to olanzapine in young adults with recent onset schizophrenia, schizophreniform, and bipolar I. Now, LYBALVI had adverse event profile consistent with our previous studies. Patients could have received up to 2 to 4 years of treatment during the trial. Now, there were 238 patients contributing to data at year 2 with a mean weight gain of 0.8 kilograms, a mean decrease in waist circumference of 0.56, and decrease of CGI-S score of 0.18. Now, there were 108 patients who contributed to data at year 4 with a mean weight gain of 2.6 kilograms, an increase in waist circumference of 1.3 centimeters, and a decrease in CGI-S score of 0.24. Now, long-term metabolic stability was noted with small mean changes from baseline and lipid and glycemic parameters. And limitations included open label design with no comparator and some missing data during the trial. Now, a second study I wanted to touch upon this morning was a retrospective real-world study compared healthcare resource utilization 6 months before and after initiating LYBALVI in 855 schizophrenia patients, 691 bipolar I patients, using claims data from April 2021 through December 2022. Now, LYBALVI was associated with significant reductions for all-cause inpatient admissions and ED visits. In patients with schizophrenia, it was a decrease of 28% and 11% respectively. Bipolar I disorder is a decrease of 30% and 12% respectively. Given these limitations of the study, no conclusions of safety or efficacy can be made from this data. In closing, we respectfully ask that LYBALVI be at parity with other branded atypical antipsychotics, which have one-step or no wait criteria to obtain access. I want to thank you for your time this morning, and I'd be happy to answer any questions that the board may have.
Thank you. The next public comment is for Caplita from Christopher Galador.
Hi, can you hear me?
Yes, we do.
All right, thank you.
Good.
Hello, my name is Christopher Gallardo. I am a senior MSL with Intracellular Therapies. I want to thank you for the opportunity to speak with you today about Caplyta, an atypical antipsychotic indicated for the treatment of adults with schizophrenia, as well as depressive episodes associated with both bipolar I or bipolar II disorder as monotherapy and as adjunctive therapy with lithium or valproate. I would like to discuss top-line results of a subgroup analysis from a prospective clinical trial of Caplyta 42 milligrams using DSM-5 criteria for major depressive episodes with mixed features, in which bipolar depressed patients were also concurrently experiencing subsyndromal symptoms of mania or hypomania. Based on the DSM-5 criteria, mixed features occur in approximately 1/3 of bipolar patients experiencing a major depressive episode. Patients with bipolar depression experiencing mixed features have a greater severity of illness, with higher rates of comorbidities, suicide, and recurrence. Consequently, these patients are more difficult to treat than those without mixed features. This 6-week randomized placebo-controlled monotherapy study of Caplyta 42 milligram in the subgroup of the 199 bipolar depressed patients was statistically significant on the primary endpoint of symptom reduction on the MADRS, with a p-value of less than 0.0001 and a moderate to large Cohen's d effect size of 0.64. Caplyta was also statistically significant on a key secondary endpoint, the Clinical Global Impression Severity Scale, with a p-value of less than 0.0001 and a Cohen's d effect size of 0.61. In this study, the most commonly reported adverse events were somnolence, dizziness, and nausea. Changes in body weight, waist circumference, and metabolic parameters were similar to placebo and not clinically relevant. There were no notable changes in EPS clinical scales and no cases of treatment-emergent mania or hypomania. Caplyta has box warnings for increased risk of mortality in elderly patients with dementia-related psychosis and increased risk of suicidal thoughts and behaviors in pediatric and young adults. Additional warnings and precautions are described in the full prescribing information. On behalf of Intracellular Therapies, thank you for considering Caplyta in your formulary decision, and I welcome any questions you may have.
Thank you for the public comment. Does the board have any questions regarding the LYBALVI and Caplyta? All right. So the next is we are going to discuss the antipsychotic use in adult topic that we've been discussing since in last month. One second. Thank you, the University of Utah, for great presentations in antipsychotic use in adult from last month, September meeting and today meeting. From the two meetings, there's conclusions that we have is the referring drug list, the PDL placement of the long-acting injectable antipsychotics is effective. As Monez has stated that majority of the use of the long-acting antipsychotic is within our referring class, only a very minority, only 3% is in the non-refer, which means our PDL's placement is effective and driving the utilization accordingly. And LAI have better adherence than the oral antipsychotic, as we also have both referring LAI and the referring oral on our PDL. From the last meeting, the majority of Utah Medicaid population have been using the antipsychotic within the recommended and the compendia max dose. Very few minors is the outliner from that. The guideline from the Veteran Affairs and the Departments of Defense and also the American Psychiatric are inconclusive on the use of multiple antipsychotic in adult. There is a proposal and the motions that we would like from the board is to have the Utah Medicaid developing a monitoring program for antipsychotic in adult according to the HR 4366, or called Consolidated Appropriations Act 2024, Section 203, that will pass from the federal legislative in March of this year. Section 203 from the HR 4366 stated that this section requiring state Medicaid program to monitor through the drug utilization review program the use of antipsychotic medications by adults who receive home and community-based services or who are in the constitutional care setting, such as psychiatric hospital. State were previously only required to monitor the use of antipsychotic medications by children. The requirement took effect 2 years after the enactment, which was March of this year. Is any discussions, motion from the board?
So do we need to move? I mean, it sounds like that's a good proposal. Do we just say move to do this?
Yes, thank you, Dr. Brinton. I take that as a motion. Do we have a second to implement?
Second.
Thank you, Dr. Weinstein.
I just have a brief
yeah.
question, if you don't mind. I was just
Yes.
looking at the bottom of this has the text for section 203 and where we have home and community-based services in institutional care settings. Would that include community living centers, long-term care facilities that aren't psychiatric facilities? In other words, kind of typical nursing homes?
I would assume so, if that would fall under home and community-based services.
Right?
Yeah.
Yeah, that's where I see the questions arising, just in my clinical practice as hospice medical director, where we have, people who are residing in assisted living step up to, you know, they'll be there for many months, sometimes longer, if they outlive their hospice prognosis, but there seems to be, you know, a real interest to, limit these medications use in certain populations. And I know there are Medicare rules as well. So I would just make sure we get all the settings and in the monitoring program. And mostly children aren't in those kinds of like nursing home facilities. So I'm not sure the monitoring, you know, if we're going to follow along what was, you know, done for monitoring these medications in children, there might be some different settings.
Yeah.
Thank you.
Thank you. So right now we don't have, right now we haven't decided how we want to selectively out certain populations in home and community-based services. That's something we're going to design. But for children's, we has foster and non-foster children's on both under monitoring. All in favor for the motions?
Aye.
Aye.
Thank you. Any abstentions? Motion pass. The next item on the agenda is the 2 PA that we review at the last meeting, the Restifa and the AQHAE. So after the last meeting in September, this PA has been modified and receiving feedback from Dr. Box. There's some revisions to this PA. Criteria for approval, all of the following criteria must be met. Is the patient 18 years of age or older? Is the medication being prescribed by or in consultation with hepatologist? Does the patient have a diagnosis of non-cirrhosis, non-alcoholic steatohepatitis, or metabolic dysfunctional associated steatohepatitis? For member with the BMI of more than 27, does the documentation show that the member has been enrolled in an approved medically supervised weight loss program for at least 6 months and either has failed to lose at least 5% of their excess body weight or have achieved 5% weight loss and continue to have persistent abnormal liver function tests or evidence of persistent hepatic steatosis on imaging? Does the patient have moderate to advanced liver fibrosis consistent with stage F2 to F3 fibrosis? Does the provider attest that the patient does not have decompensated cirrhosis? Is the medication being used in conjunction with diet and exercise prescribed in chart no? Has the patient been compliant with taking stable dose of medication for diabetes, dyslipidemia, hypertension, if applicable? Has the provider checked baseline liver function tests? Reauthorization criteria all must be met. Is the medication being used in conjunction with diet and exercise as described in chart no? Has the provider submitted updated liver function tests with the request? Has the provider submitted an updated letter with medical justifications or update chart notes demonstrating positive clinical response? Initial authorization is up to 1 year and re-auth is also up to 1 year. Is there any common feedback from the board?
On number 8, do we want to just make a slight change to the language where we don't use the term compliant? We could say something like patient's been taking regular, stable dose regimen or use the treatment adherence. I think we're getting more and more asked to use that some alternate language there.
Maybe adhere. Adhere.
Adherent would be the adjective. That's with a T, adherent, sorry. With, I think it's adherent with, right? So we might say, has a patient been adherent with taking, if other people have a better suggestion, I'm a little under the weather, thank you.
Any other comments, feedback? If not, do we have a motions for the PA?
Motion to approve.
Thank you.
Okay.
Thank you, Dr. Brinton. All in favor?
Aye.
Aye.
Any opposed? All right, motion passed for the Restifra PA. The next one that we have is the acute hereditary angioedema. This is include the Berinert, the Firazi, the Calpitor, and the Ruconest. And this PA also has been going through some feedback from the DRRC and incorporate the feedback from them from their PNT review on the HAE topic. Criteria for approval, all of the following criteria must be met. Does the patient have the diagnosis of hereditary angioedema type 1, type 2, or type HAE NLC1INH? Is the medication being prescribed by or in consultation with an immunologist? Has the provider educated the patients on avoiding HAE triggers? Additional criteria for Berinert, is the patient at least 6 years of age and older? For Firazi, is the patient at least 18 years of age or older? For Calpitor, is the patient at least 12 years of age or older? For Ruconest, is the patient at least 13 years of age or older? Does the patient have a history of allergy to rabbits or rabbit-derived products? Does the patient have history of laryngeal attack? For reauthorization criteria, has the patient has an improvement in severity or durations of attack demonstrated in the chart? No. Quantity approved, most of them is approved more than at least 2 to 3 doses at the time of approval, except the Barinus is only 1 dose. It is the IV product. For initial auth, it's up to 1 year. For reauth, it is also up to 1 year. There's a note on the anaphylaxis for the administration of catheter. Is there any feedback, comment on this PA?
Sorry, Noon, I lost my connection for a second there. Do we need a motion on this then from the board?
Yes, that would be great.
I would move to accept. It sounds like there's no concerns.
Thank you, Dr. Brinton. Do we have a second?
I'll second that.
Thank you, Dr. Sikri. All in favor?
Aye.
Aye.
Thank you. Any opposed? No. Okay. So with that, that is all of our agenda for today meeting. The next meeting will be in November 14. This will be a lot of, not a lot, the multiple PA from the rare disease PA that we split from. I will be sending the board on of the draft of those PA along with their prescribing informations. We will try to go through several PA at this meeting if possible. So please review the material beforehand. And with that, do I have a motion to adjourn?
So move.
Thank you, Dr. Brinton. Second.
Second.
Thank you, Dr. Weinstein. All in favor?
Aye.
All righty. Motion adjourned. See you all next month.
Have a good day.